Welcome back. You're watching Morning Express, and we want to leave you with this particular story that highlights the journey of universal healthcare coverage and the steps that have been taken so far. So you will remember that in 2018, President Uhuru Kenyatta announced universal health coverage as part of his Big Four agenda. This initiative is aimed at ensuring equitable access to quality healthcare for all in the country by the year 2022. We're only a few months away from 2022. So what is the current status of this ambitious project by the Jubilee government? Our science and health reporter, Gloria Milimu, takes a closer look on this health agenda in this KTN News special report. Take a look.
Achieving universal health coverage is one of the targets nations of the world set when adopting the Sustainable Development Goals in 2015. And in 2018, Kenya embarked on this ambitious project, listed as one of the Big Four agendas, aimed at ensuring that they receive quality and affordable healthcare services without suffering financial hardship. In December 2018, the government rolled out UHC on a pilot phase in the counties of Machakos, Isiolo, Nyeri and Kisumu. Health services in these selected counties were offered free of charge, and the experience by the beneficiaries varied.
I had a keloid growth surgery, and it costed around 21,000, and it was paid with UHC. And after that, there was also a complication. I was supposed to have the second surgery, and it was still supposed to be paid by UHC.
I was registered in 2019, whereby the CHVs came door to door, and I have really benefited from UHC. I've also managed to go to Nyalenda Health Center severally, in occasions whereby my son was ailing, and I was able to get the services free of charge. The only thing I paid for was the patient's book, but the services and the medicine was free.
Kwa advantage ya hii kadi ambayo tuliona ni kupata hiyo matibabu, ndio imesaidia sasa, kwa sababu ni matibabu bure. Kwa sababu hata kama ulichafua kwa NHIF, ukiwa na hii unatibu bure.
The pilot was meant to demonstrate feasibility and cost implications of providing full health insurance for everyone, test the health system's ability to respond to an increased demand of health services, and the ability of NHIF to enroll many more people. This pilot was to inform rolling out of UHC to the rest of the country. Even though the pilot project managed to remove the burden of paying out of pocket for health services, some patients still had to purchase medicine that was more often than not available in some facilities.
Ile challenge nyingine ya pili tuko nayo, wakati hizi kadi uko nayo, unakuta unaenda unapata matibabu, unakuta dawa kidogo inakuwa challenge. Upande ya dawa inakuwa challenge kwa sababu unaandikiwa, unaambiwa hii na hiyo ugonjwa wako, lakini wakati ya dawa unakuta zile dawa unahitaji haupati.
Under UHC, the national government will offer health services to everyone regardless of their ability to pay. And when UHC was rolled out in the 4 counties, it was a financial relief for most residents who registered under the program.
I could say that UHC has really been helpful, especially to us who are in the informal settlements, because you find out that we have financial difficulties, and it was a point whereby my NHIF was not functioning, I was not paying. So paying for the medical expenses was quite a challenge by then. So UHC came in handy, whereby I could access the medical services free of charge.
Lakini siku hiyo kitu ilikuwa iko ya kutengeneza watu bure, huko ilikuwa inatusaidia saidi. Kwa maana ukienda general unaandikiwa dawa ukanunue nje na una pesa. Sasa hii inagadi sasa ukatafute mavibarua ya kufua nguo ndio upate matumizi ya kutunulia watoto madawa.
In order to secure sustainability of financing for health, I want to urge both levels of government to ring-fence health sector funds to support the attainment of universal health coverage.
We have good brains in this Kenya. The problem we have had is trust in each other. And because there is no trust, implementation becomes an issue.
At the time when the government was launching the pilot phase, some counties had already embarked on strengthening primary health care, setting the pace for universal health coverage. One such county was Makueni, that came up with Makueni Care, that saw residents register for health care with 500 shillings, and the government topped up with another 500 shillings.
In Makueni Care was a product of a strengthened primary health care system. I think between 2013 and 2015, as a county, we focused on improving the primary health care system, increasing the community health network, increasing the primary health care facilities in terms of level 2s and then level 3s, improving access to the facilities so that people are able to access services nearer their homes. And through that, we increased the number of primary health care facilities from about 90 to 226 within the first 4 years.
The county also revealed that prioritizing matters health through budget allocations has helped improve services in the county. For a country like Thailand, where Kenya is borrowing a leaf from in its effort to attain UHC, its model of UHC financing is tax-based.
Civil servants and beneficiaries like me, which is around 5 million people, 7–8% of the population, the smallest group. This is totally tax-based. The scheme is the social security, employment-based. Those who are employed will have to pay out of their salary certain amount, certain percentage. For health, it's 1.5%. This covered maybe around almost 17, 18, almost 20% of the population. The rest, which is about 75% of the population, are covered by so-called Universal Coverage Scheme, UCS. So you have two terms, UHC, mean everyone. And then the first scheme, Civil Servants Medical Benefit Scheme. Second scheme, Social Security Scheme. Third scheme, UCS, Universal Coverage Scheme.
Thailand launched its UHC in 2002, and by the year 2011, it provided 98% of its population with subsidized health care. In 2019, Thailand signed a Memorandum of Understanding with Kenya to collaborate on UHC. The MOU focused on helping Kenya achieve UHC in 3 areas: insurance and financing, prioritizing benefits packages and technology assessment, and human resource development. In the pilot phase, the health services were funded through the county budget allocation, conditional grants from Danida and World Bank, Level 5 grant, user fee forgone, UHC grant from the national government, and user fee paid by clients not registered under UHC. A total of 3.97 billion shillings from the Exchequer was allocated for a year as an additional financing to counties for the pilot phase, focusing on community and primary healthcare services, health system strengthening, basic and specialized medical services. Isiolo received an allocation of 725,719,086.40 shillings, Kisumu 876,121,179.15 shillings, Machakos County received 787,524,789.15 shillings, and Nyeri 780,801,105.83 shillings. The selected counties were expected to integrate UHC into their health systems in a model that will be adopted by the rest of the counties.
Going forward, each and every Kenyan will be entitled to a quality health care package that is accorded to them as a right, not a matter of privilege.
However, Questions on the sustainability of this financing model continue to linger on.
The best time to achieve UHC is not tomorrow, it is today. But we know that it's not always practical, that we have to take time because there are many challenges. Those challenges have to do with financial affordability, or what we call fiscal space, the ability of the economy to afford to give all people everywhere access to services they need without financial difficulty. That is a financial challenge. And many of the African countries, including Kenya, have that challenge. The next thing to look at is the legal hurdles that may be on that road towards the universal health coverage. There are many things you need to look at when you're looking at universal health coverage, and some of them have to do with how do you raise revenue? How do you raise the money you need? From who? But secondly, it is how do you spend the money? On who?
To ensure its sustainability, experts advise on the need for collaboration between the two tiers of government, considering that health is a devolved unit.
So when the national government puts its foot down and says we want to achieve UHC, it cannot succeed without working with county revenue, because the counties receive the revenue share, and what part of that, between 25 to 30% of that revenue share, is actually put into the health sector in the county. So when the national government decides to achieve UHC, the biggest partner is actually the county government, and that has to be not only a partner in policy implementation, but also a partner in revenue. So we saw in the pilot that some of the money the county governments were using for the health sector in their counties got crowded out by the national government money. And therefore there wasn't, in many cases, we failed to demonstrate incremental investment from national government. And it looked like whenever the government put money, the counties removed part of their own money.
We have a newborn in town, and this newborn will have teething issues. We'll expect some challenges, but unless we begin the journey, we will never overcome challenges because they won't be there. So we need to begin this journey and address the issues as they come. We have agreed with the chair of the Council of Governors, Governor Oparanya, that as these things come, we will also cooperate and coordinate our activities.
Adoption of a mandatory health insurance contribution for everyone who is formally employed to cater for the poor is another strategy experts recommend for the attainment of UHC.
The revenue raising, now the government has actually gotten to where we think is the right place to be, where you say on one side, you have the former employed people who are contributing through the National Hospital Insurance Fund. That has always been there. And that's a mandatory tax for anyone who is formally employed. Then you ask, how do we get the poor, extremely poor, to also be able to contribute? Then you start to ask yourself, how do we identify the poor? So the government will then use its money to pay premiums for these ones. Then you're left with what's called the missing middle. If you take care with taxes of all the poor people, and all the former people pay through the mandatory NHIF deductions, then you have that middle, who are not poor, they're in informal business, because Kenya is 80% informal economy, and then you have already the ones who are contributing mandatory NHIF. Then you have that missing middle. The big question, the million-dollar question is, how do you make this missing middle contribute? Because the ideal of UHC is to pool money together and then spread the risk across everybody, so that no one is needed to pay for their costs on their own. It is pooling. Now, if the government has pooled for the poor and the individuals who are employed have actually contributed from their salaries, this missing middle, you have to find mechanisms. The mechanisms that are needed include mandatory national health insurance or national hospital insurance contributions. Mandatory means that you have to find mechanism to tie business licensing, the tax system and all these to the payment of NHIF, so that people can then be forced to pay. And then when they pay, as long as they can afford. And those who can't afford, as I say, it should be the responsibility of the state. But those who can afford, You know, people who own matatus, people who own butcheries, who own bookshops, who own shops. These people who actually can afford 6,000 shillings a year for their families should be made to pay by finding mechanisms that tie the NHIF contribution to their business environment. Then if you do that, you have enough pooling of money. Then number two is, you need to reform the NHIF. Reform NHIF to ensure there is accountability, that you reduce the amount of money that is used in administrative activities. And I think we've made some progress on that. We've come down from about 18% of the NHIF money being used on administration, almost 19%, to about 10%. So that needs to be done, so that majority of the money in NHIF actually goes to services. Secondly, is around removing fraud and increasing accountability.
I want to make it clear, the scheme we are launching today must be a success. In this context, I urge the NHIF to ensure that the precious funds committed to its custody by both subscribers and supporters are utilized prudently with utmost transparency and accountability. Any person who attempts to defraud the NHIF or abuse its processes will be dealt with accordingly as provided for under our laws.
More than a year later, UHC appears to have run into headwinds, leaving many Kenyans struggling to access basic health care, and the future of UHC looking bleak. NHIF says the model of financing UHC is input financing that entails health facilities being provided with everything they need to facilitate access to free treatment by members registered under UHC. However, this model requires constant supply of cash to purchase commodities needed to take care of human resource, and this, according to the National Insurer's Chief Executive Officer Dr. Peter Kamunyo, is not sustainable.
The alternative to that input financing model is what we have embarked on now in UHC scale-up through NHIF. And this is what we call output financing, or it's more like it's an insurance model, whereby the individuals who are registered have their premiums paid up to NHIF, and then they have access to the network of providers that are empaneled by NHIF. So when they go and seek services and consume services, the facilities claim for those services and NHIF reimburses. So this creates a loop of financing that is sustainable. So the members who can pay their premiums every year. Those who can't pay are identified and supported, and then they seek services in the facilities in their areas, and those facilities claim for reimbursement. So this creates a cycle that is sustainable. And these are models that work also in many other countries and have been tried and tested.
Most people stopped paying their monthly NHIF contributions, believing that UHC would cater for their health needs. And experts say this has affected NHIF financially, the vehicle through which the government hoped to deliver UHC.
I invite all Kenyans and all persons resident in Kenya to register for NHIF and to ensure that they remain up to date with their subscriptions. This will ensure that the fund has the necessary financial depth required to deliver on its very important mandate, in addition to ensuring that in the event of a medical emergency, the fund is able to step in and cover the paid-up member or their beneficiaries.
For success is that for every Kenyan to be a registered member of NHIF. And how is that possible? It is possible by ensuring that all who can pay actually do pay, and those who can't pay, we identify them and support them, which is what the government is doing right now with the first phase of supporting 20% of the identified indigents in this country so that they can be able to access the care. And using those models as well is the success is also dependent on the service delivery or the service provision. So our healthcare providers, especially in the public sector, need to be consistent and provide consistent quality care so that the members can be able to get care without paying a single shilling.
A recent report by NHIF revealed that 10 million Kenyan households have enrolled with NHIF, but only 5.6 million were active as of May.
I want to assure you that my government, in consultation with all stakeholders, namely the county governments, as well as our development partners, will incorporate lessons garnered from the pilot phase, as well as international best practice, into the preparations for the national scale-up of UHC. In scaling up the implementation of UHC, we will focus on 5 major pillars. The first is what we are here to witness today, which is to scale up the reforms at NHIF, which shall be comprehensive and fully implemented to ensure that the country has a national social health insurer that is able to responsively meet the needs of Kenyans by strategically purchasing services for their health and well-being. So in this regard, today, I direct the Ministry of Health and the Attorney General to fast-track the necessary legislation that will codify these reforms into law and foster the sustainability of the fund. The second is to establish a mandatory UHC scheme which will be managed by NHIF and regulated by the Ministry of Health. And it will act as a national scheme for all persons resident in Kenya, notwithstanding one's social status. 3, adopt the Essential Health Benefits Package, which is already completed and which will enable Kenyans gain access to an essential set of health services at a much lower cost. The package covers several areas, including outpatient and inpatient services, communicable and non-communicable disease management, maternity, dialysis, radiology, minor and major surgery, substance abuse, rehabilitation, emergency services, and cancer treatment.
With only a few months left to go before the 2022 target for attaining UHC lapses, it is now a matter of wait and see whether the government will beat the deadline and ensure that its people are safeguarded from the financial consequences of paying for health services out of pocket, something that has impoverished families. Gloria Milimu, KTN News.